Well, except I can't see it now.
Okay.
All right, and now we want to go to, sorry, I'm having trouble finding my my presentation mode.
That happens all the time. While you're doing that, Anjali, you want to go ahead and introduce yourself while Mike's looking for his mode?
Absolutely. Hi, everyone. I'm so happy to be co-presenting with Dr. Dell. My name is Anjali Kumar, and I'm a surgeon. So I'm going to be telling you a little bit about how I used the WISE MD modules in a way that we were able to level set some of the clinical variability in the institution that I work at. As Dr. Smith, Sherilyn Smith, pointed out, I'm in a new medical school. It's Washington State University. It's on the other side of the Cascades in Washington State, but it's actually spread across 4 different campus areas in Washington. So I've got students in the Everett area, Vancouver, Spokane, and Tri-Cities, which incorporates a lot of variability in their clinical setting. Dr. Dell, I see that you're on a slideshow mode, but we see a blank screen. Is that what you see?
No.
And Mike, if you want to unshare, I'll be happy to share. That would help.
I think I'm going to take you up on that offer.
Terrific. So if you just unshare and you can go ahead and introduce yourself. And I can share now in a moment, I think. Or maybe I can just do that and I can cancel out your sharing.
That'll probably work.
I don't know why. So thank you guys for bearing with me and my technical incompetence. You would think after 10,000 hours of Zoom meetings, I would be proficient, but apparently I'm that slow learner in the crowd. Sherilyn introduced us already. I'm Mike Dell. I'm the Senior Director for Aquifer Pediatrics and the Vice Chair for Education at Rainbow Babies and Children's Hospital. We're going to talk about several pearls today. I'm going to start with the first 2 and then turn things over to Dr. Kumar to talk about some of the innovative ways she's been using these products with her surgical students. If we go to the next slide, I will share a little bit more background. Sherilyn alluded to some of the origins. The project was started by the authors for the original HRSA grant were from New Hampshire, and they literally used a case example in that initial grant to say, our patients here at Dartmouth are just not seeing patients like those with sickle cell disease. We need a platform by which we can account for some of the geographic and seasonal variability that's affecting our learners, and made a cogent argument that this affected quality of care. And those problems still exist for all of us today. What has been greatly enhanced within Aquifer is your ability to find that material. So when we started this, the original CLIP cases would be CLIP 1, Bobby. And you had no idea what the Bobby case was about unless you went through and did the Bobby case yourself. And then, but only then, could you tell your students, here's what you'll learn out of this case. So the search option that Sherilyn was showing you is so powerful. She happened to pull up one of the ways you could sort the cases by going to neurology. What you've seen I've done here on the screen is search both by neurology and then by pediatrics. And there are several cases, but these are the first 3 that came up. Once I've got that list of cases, if I click on case synopsis, it's different than the case summary she pulled up, which is the notes from the entire case. I pulled up case synopsis, and you can see here in this one small box, an outline of here's the storyline. The chief complaint, here's the symptoms that you'll cover, the differential diagnosis that's covered in the case, and the final diagnosis. And so very quickly, you can find those cases that you're looking for. This could be for someone who is struggling with that piece of the curriculum. It could be a student who's not met one of the learning objectives for your course. It could be that you just have students who have that FOMO. You know, I'm on the pulmonary team, and Dr. Dell, I hear my classmates learning about all these cool neurology cases, and I feel like I'm missing out on part of my education. I really like the Aquifer cases. Can you tell me what cases I could do to catch up with my classmates? So there are lots of ways. There are lots of ways that you can use this search function. Next slide. From the inception, the power of these cases is that they stand alone as learning exercises, and you truly can assign these cases to your students as independent learning exercises and know if they go through it in a conscientious way.
Welcome back, everyone.
Thanks for bearing with us. So one of the things that I was saying about these cases is that they are intended to be standalone learning exercises, and that's a perfectly acceptable way to use them. I will tell you that as one of the original case authors, every one of us as a case author felt when we were done writing our case that we had left so much teaching out of the case. There's so much more I could have covered. And I will tell you that overwhelmingly when we survey students about how they like the cases, their number one complaint about the cases is they're way too long. And so we know that there's much more to teach and we just can't cram any more into these cases. So in the 12 to 15 years I've been using these cases, I have spent most of my energy finding ways to create discussion sessions to enhance the cases without making them longer, giving the students a chance to go through the material, but then apply it under the guidance of a resident or faculty member. I've gone so far as to incorporate this into our resident as teachers curriculum, so I'm addressing two needs with one exercise. And I do a lot of coaching then for our residents. How do you run a discussion session around a case that they have already done? Don't walk them through the case, they can do that. So one of the important principles, I think, is norming. If you have a learner who has seen a single case of an illness, they will naturally identify that subconsciously as the red part of the curve. I've seen one case, that must be the typical case of asthma, of appendicitis. You may realize that the case they've seen because it came into the hospital is over in the blue area at one end of the bell-shaped curve. And having somebody like a senior resident or faculty member who can say, no, the case you just did is representative of the severe end, the medium end, the mild end. Let's talk about other faces of asthma, other faces of children with UTI. Do all kids with UTI need to be admitted? The kid in the case was, but not every kid does. When would we send this kid home? What would we send that kid home on? The kid in the case got an ultrasound. Most adults with UTIs don't get ultrasounds. What's the age at which you stop getting ultrasounds on every patient? So teaching some of those general principles, and I will say them when I coach my residents. You saw Sherilyn bring up the fact that there are deep dives, sort of the extra credit learning, if you will, all of which comes with references. I don't expect most of the students will do all of that reading. I absolutely require that all of my teaching seniors do that reading. And if they haven't done reading like the AAP clinical practice guideline on UTIs by the time they're a senior resident, this will be the moment that they dive in and read those guidelines to the point that they could teach it to someone else. Next slide. There's only one possible outcome for each case, and I think that students naturally gravitate towards, I want to get the right answer. How does the case turn out? I think many of us as educators might offer that it's the journey, so to speak, that's almost as important or more important than the destination. And so I will encourage my residents and I'll encourage the students when I run the small group discussion section to go back to all of the things in the case that it didn't turn out to be. Here's a differential that was pulled out of, I believe, the Kawasaki disease case. Great, you all know how that case ended. How would we have to rewrite this case to make the answer turn out to be measles? How would we have to rewrite it to make it turn out to be scarlet fever instead? And that compare and contrast exercise, as we all know, is a critical part of clinical decision making and clinical reasoning. Next slide. We've talked about a lot of content that you can teach to your students, one of the other things that I find, especially now in this pandemic area, that they're missing out on, students are great at absorbing content. They can read textbooks, they can read board review books. The hard part for them on the clinical rotation is often identifying the decisions that need to be made. They think if they took a good history and made a diagnosis, their job is done. This is a little schematic exemplifying an imaginary student presenting to Leslie Fall as his attending. And in his mind, he's saying, Bobby's a 2-week-old with fever with the caption of a crying baby. Meanwhile, Dr. Fall is thinking, well, what's wrong with this baby? What workup should we order? How sick is the baby? Do I need to stop the presentation and go see them now, or can I wait until this student finishes talking? Is this a normal host? Does he need an LP? Does this student know how to do an LP? Is he going to ask me to help him do the LP? Will there be any long-term sequelae? Could this have been prevented? Does anybody need prophylaxis? We make thousands of decisions every day, and students often see 1 or 2 of these questions. Senior residents are amazing at identifying all of the questions that need to be answered today, from preparing for discharge to cohorting patients to treatment options to doing procedures. So I really emphasize to my senior residents, help your students see these questions. Next slide. And this is a gross example. I apologize that the type is so small. Those of you with Zoom sophistication know that you can enlarge the image on your own screen. This is the newest of the exercises that I did for my acting interns who are having a foreshortened rotation. They have 3 weeks instead of 4. And I realized that most of my AIs, when they hit the rotation, spend the first week wandering around somewhat confused, learning the ropes, and now I don't have time for them to do that. So I sat with 3 residents. We came up with 3 emergency cases, a respiratory, a cardiovascular, and a neuro case. And then things we think AIs need to know going down the left side, starting with content, but then practical skills. How do you write fluid orders? How do you write a medication order? Do you have a seizure rescue plan? How do you manage pain? How do you perform an LP? Their communication skills. How do you give sign out? How do you call a consult? How do you give bad news to a family about a concerning diagnosis? And we made this curriculum map so that my 3 residents ran a teaching case once per week over 3 weeks. The students who are about to start their AI joined by Zoom, and we mapped out that, okay, well, in the neuro emergency, we're also going to run a video about how to do an LP. We're going to then pull up our practice environment of the EMR and show them how to write a procedure note for the LP that they just performed. They're going to get consent for the procedure, so they'll go over how you get consent in the hospital. And they took a case that was relatively straightforward, and the students felt like, yep, I got the content. Now I know about kids with seizures. And what they added was all of this sophisticated senior resident level, how do I get stuff done in the hospital? Our AIs loved it and felt they just started on Monday and hit the floor feeling so much more prepared than any previous group of AIs I've ever had. Next slide. I think I'm going to pass on this one because I know that we got derailed a little bit. I'm going to turn things over to Anjali, and if we have time at the end, we'll come back to this.
Thank you so much, Michael. So I loved what Dr. Dell said about using the cases in Aquifer as a springboard. And one of the things that I wanted you all to consider was also using it as a stage. When we're teaching exclusively in a virtual format, which is what I'm going to describe to you, just in case, you know, we need to go back to that 100% virtual format, we can keep in mind that our students always want to be challenged and that they'll all be coming to us at different sort of clinical maturity levels and experiences that they have previously seen. So if we consider the core and trustable activities, professional activities for entering residency, of which the AAMC have defined about 13, and they're working on a 14 and a 15. I'm going to paste them into chat right now so you can see them. But one of the things that you could consider doing is to increase the complexity and sort of simulate an increased entrustability in your student simulations as time goes on, or whatever time you might have goes on. And I'm going to give you an example as to how you can do that. So let's go to the next slide, and I'll tell you a little bit about how surgery had an additional challenge using the Aquifer platform. And that is that WiseMD, and it's undergoing some updates as we speak, but WiseMD is formatted a little bit more like a textbook, where we have certain modules that are almost like chapter titles that cover, in a case-based format, certain topics. But because of that, it's not every module is written as cleanly from start to finish as like a case, like the Aquifer. So even to get here for surgery, you have to hit a button on the top of a blue button on the top of your screen when you're in Aquifer to enter into WiseMD, and then you'll see a screen similar to this. If you'll notice, the case modules are kind of chapter-like based, whereas the skills modules are about some procedural skills. What I ended up doing was saving all those skills modules for 4th year and using the case modules for 3rd year. And I say saving because I'm anticipating that we'll have another wave and that we'll go back to a virtual format. So I wanted to kind of understand what all I had available to me and stage it so that I could be flexible and nimble enough to deliver content at a moment's notice. So we'll go to the next slide, which you'll see the way that I decided to divide up the content that was available on WiseMD. There were 22 modules, and I grouped them like this into 3 different groups. And I can imagine that you could do the same thing using some Aquifer topics, like for example in pediatrics, similar to what Dr. Dell said about the neurologic, the cardiac. You know, you could have different kinds of subjects that were covered. For us, when we shut down for COVID and all of our students went to an exclusively virtual learning platform for their clerkship, basically overnight, I was given 1 week of time to work with them exclusively on surgery. Our medical school is a little unique because we have a longitudinal integrated clerkship format where they had actually done 2/3 of their surgery experience before coming to me for the virtual clerkship. So I was happy that they had been in the OR and that they had seen some things. I actually surveyed them before we started the virtual clerkship to see what learning gaps they had in their prior clinical environment. So that's something you can consider to manage clinical variability, and then assign them to the group that makes sense for them. And if you can make one more click, there's another slide. Yes, so this is my faculty that I recruited, and the beauty of this being in the virtual format, at that time, you may recall all elective surgeries were ceased. So the surgeons in our faculty had a lot more time to give. But I was able to recruit statewide faculty and then pair them together, and be able to recruit some surgical subspecialists also, because you know, general surgeons, we're at a workforce shortage actually in Washington State. So some surgical specialists were able to come in and feel comfortable enough with the way that we had grouped the subject material that they could pretty much carry that that course content load. Okay, and so we'll go to the next slide, and I'll tell you a little bit about how we constructed the week and how my pearl to you is to mix it up, but do so in a staged manner so that you're increasing your complexity and increasing your variability, your entrustability as the week progresses. So because WiseMD was formatted in more of a chapter format, I had the students create their own case. And I asked them to just create a garden variety case of the most common presentation. And then in the first 2 days of the virtual rotation, really focus on these bulleted core skills. And we'll click one ahead. If you notice that on the, oops, one back. And if you notice on the Thursday and Friday, I tried to twist it up by having them increase a comorbidity or an anatomic variation or an unexpected finding during the operation. And really worked on some of those higher level skills as well, which is management of a postoperative complication, transition of care, and calling consults. And that is the sort of sounding board or stage that I wanted to set before we open up for some discussion. And I noticed that what I tried to paste into chat didn't come through, so I'll work on that while I field some questions from all of you.
Terrific. So we don't have any questions in chat right now. If anyone does have questions, we've got about 6 minutes still available. Thank you for bearing with us. There are challenges, and I'm sure Dr. Stell and Kumar will be happy to answer them. I'm going to give it another minute. If there's no questions, Mike, maybe you can go back to that last slide to go over the last piece of the pearl that you wanted to share on additional threads.
You know, I was thinking the same thing.
Terrific. Why don't I bring you back there in the slides? Oh, I'm getting a yes, please. Okay. Thank you. Welcome.
So, you know, one of the other, Sherilyn was whizzing through fairly quickly. And one of the things that she landed on during the general session was the educator resource session. I opened up here the pediatric educator resources, and one of the subheadings here you'll see is questions for further analysis. Again, this goes back to the way I coached my residents as teachers and even some of my faculty as teaching attendings. For each of the cases, so this spreadsheet has questions that you might use as discussion prompts for each of the cases. It was a little bit too large to put the entire spreadsheet into a slide, but if you could explode this and see the whole spreadsheet, what you would see is that there are typically 5 or 6 questions for each, follow-up questions for each of the cases, but the spreadsheet sorts them into different categories. These go a little further afield than the examples I was showing you before. So for example, you can see some of the questions here, a 14-year-old female who presents with abdominal pain, and the question of confidentiality comes up. It doesn't actually come up in the case, but this might be your opportunity to go through with your student or your novice resident. How do you ask a parent to leave the room and respect a teen's confidentiality? And what do you do when they challenge that confidentiality? There's a case in which we have a teenager who's pregnant. And one of the questions for further analysis is, do you know what the rules are for emancipated minor in your state? They're not national guidelines, they are state by state. Do you know where to find that information, and what is the standard in the state where you're practicing currently? There are medical legal questions, there are epidemiologic questions, there are questions about higher level management. So again, you guys have all seen your house staff. You know that your residents and even your junior faculty, some of them are just natural born teachers. They don't need this resource. You give them the case and they will come up with 20 great questions on their own. But for the ones that are struggling and saying, hey, so what should I ask? How do I get them talking? None of the students want to say anything. I found that this was a very powerful tool for giving them a jumping off point. And then once the conversation is rolling, they can generally take it from there. So thank you for taking us back to that, Eileen.
I was able to post the EPAs, the Entrustable Professional Activities. There are 13 of them right now, and they do kind of increase in complexity and clinical maturity as they increase in number. So I'm happy to take any questions about that.
And we have about 2 minutes till we will disappear back into the main room. So you're actually, oops, sorry. If you'd like to, you can unmute yourself and go ahead and ask a question.
I might also add, you can unmute yourself and share another great idea. If there are those of you who are using these cases beyond that initial role of just assigning them to your students, we would love to learn from you as well.
And I have a couple clarifying points that I'll wait as people, and feel free to jump in and interrupt me. So Dr. Kumar is talking about the WISE-MD course, which we distribute on behalf of our partners at the New York University Grossman School of Medicine. Dr. Tom Riles, I think, is on the line with us, and he is in charge of the SIM Center there and is the I don't even know how to introduce you, Tom, but the founder of the WISE-MD courses as well as the WISE on Call. So they look a little different because we distribute them on behalf of NYU, but they are available through Aquifer. The pediatric educator resources that Dr. Dell's been referring to, all the educator resources are available on your courses page within Aquifer. There's a section that says educator resources. You can click in there. There's a whole bunch of rich resources. The questions for further analysis are something that's available exclusively with the pediatrics course. Thanks to Dr. Dell and our course board that has worked on there. They have very, very rich resources, especially with the pediatrics course. We have 1 minute left if there's anyone who has anything to say.
I just wanted to ask Dr. Dell, my name is Monica Cifuentes, and I'm at Harbor UCLA obviously in California, an affiliate of UCLA main campus. And I found it interesting in terms of, you said you use this in your curriculum for residents as teachers. Do you have like a set number of cases that you choose that for every group that comes through, your resident will incorporate those either in the nursery or in the inpatient?
Exactly.
How do you structure?
When I started doing this, we actually removed certain lectures from our didactic series. And if the content of the case was similar to what had previously been a lecture format, I would take it out of the lecture cycle and typically create a noon conference. So for example, if I knew that there were going to be house staff meetings during the month where students wouldn't be invited, I would say, great, that's perfect timing for, that's when these students are going to get together with a senior resident and run these teaching sessions. And as you say, they can be adapted to the nursery, they can be adapted to the outpatient clinic. I use them primarily on our inpatient service. You're muted.
Did you assign the case before?
Yes.
So that both the student and the resident reviewed it? And
yeah, once and only once did I make it an unknown and have the senior resident literally clicking slide by slide. Okay, what do we learn on this page? It was deadly boring. Everyone hated it. And so now it is, this was before everything was referred to as a flipped classroom model. It was everybody complete the case the night before and come to this small group discussion ready to discuss the virtual patient you all admitted last night. And I would encourage the senior to run it like rounds with your team of students, but then expand the discussion to all of those things we couldn't get to within the case.
Yeah. And it's much more interactive than the lecture.
It's so much more interactive than the lecture. And what has really been validating for me as a longtime member of the PEDS project, you saw Sherilyn flash some numbers about over 90% of the allopathic med schools in the country using these cases. Virtually all of my senior residents now will start the coaching session with me by saying, oh, I remember these. I did them 5 years ago as a student. And then they will come back to me after running the teaching session saying, oh my God, there are so many things in the case I see now that I just didn't see when I was a third-year student. It's like watching a Disney movie as a parent.
Right.
And there are those jokes in there that you know are directed at the adults that the kids don't get.
Right.
And that has been the greatest part. I'm like, there it is. That's what you teach. That
Great.
Stuff you didn't see as a student. Let the students see what you see with senior resident eyes.
Perfect. Thank you.